So what I wanted to do, I'm going to try to start with this, which I think is to some extent the idea of the origin of this group, was to tackle this problem that heart disease and stroke are the first and third leading causes of death in California. And I think that's essentially the Right Care initiative is aimed at trying to change that. And I want to talk a little bit about the approach that we at least have taken and the results that we've seen in trying to change that situation. So I'm going to go fairly quickly across a range of different activities that are really meant to encompass both the primary and secondary prevention of a stroke and heart attack, but also the acute treatment. And in the course of doing that, I'm just going to point to a couple of things. One of them is that the question that we had this morning about, is this something that only a large system or an organization that's risk-rich in technology can do? And I hope I'll shed a little bit of light on that. The other thing is I'm going to probably tee up Dr. DeMaria's conversation a little bit by spending a lot of time talking about statins, just to sort of point to the statins, and then we can have some discussion about where they're useful and where they're not. So just very quickly, if we're going to really be successful at both reducing the amount of stroke and heart attack and increasing the survival from those events, we have to do a lot of different things. There's a lot of different things we can do. So we can start by helping our patients to change the things that are under their own control, to modify their risk factors through changing their lifestyle. And I'm just listing things here, really, that they can work on and we can help them with. Exercise, weight loss, smoking cessation, eating better, and just listing on the right side there some of the things that we've done that have had an impact here. And there are some real good technology opportunities. So as organizations do acquire electronic health records, they can do these things, but you can do them independently of those as well. But we now have a prompt that, among the other things that we harass our patients with, we ask them virtually incessantly how much they exercise. I can tell you, I went to my dermatologist the other day, and the medical assistant said, "How much do you exercise?" And I said, "About 30 minutes." And she said, "For how long?" And I said, for 25 years. And her form didn't allow her, she really meant for how many minutes, how many times a week. But you cannot escape our attention without being prompted about how much you exercise, and we can show that that has resulted in greater and self-reported increases in exercise among our patients. So just some examples, and then finding ways to support patients who want to change their habits through referrals to health coaching, and again, there are opportunities to do that in person, online, etc. In addition, more in the hands of the healthcare system are doing those things for patients that will control their underlying cardiovascular risk factors. We've heard a substantial amount today about hypertension control, and similarly around lipid control and blood sugar control. There are opportunities. I'll point to a couple of specific things here, but I think we've heard quite a lot about this already. And then secondary prevention for patients who've already demonstrated that they have coronary disease or other cardiovascular disease or equivalents. There are great opportunities to both find them and to implement interventions that can improve their risks. And you've, again, I think, heard many of the elements of this from people earlier today as well. And then I don't want to forget the fact that we're not perfectly successful at prevention, and that it's important, as we just heard from the Stanford group, to be competent at managing patients when they show up, those patients who still show up with heart attack or stroke. And again, here's some things, and I will spend a little more time on this because I think the issue of the role of the electronic medical record here is one that's important to understand. The use of statins in the setting of acute events is worth knowing about as well. And then I'm not going to talk about it, but I just want to mention that pneumonia prevention in stroke patients, pneumonia prevention in general in hospitalized patients, I think is an important issue. It's actually a far more frequent cause of harm for patients than having a heart attack is acquiring pneumonia in the hospital for whatever reason you came in. So I'll just reiterate some of the things you heard before just quickly, and I'll start with, I believe the number one tool that is useful in managing patients with hypertension or virtually any other ongoing condition is, in fact, a registry. If you don't know who the patients are, you are really hampered in your ability to take care of them. You're just sort of faced with opportunistic things. The patient happened to show up, so now I can take care of them. You don't know that they didn't show up, and nor do you know whether you've been successful in your treatment, nor do you, for that matter, necessarily know what treatments you or others have rendered if you don't have a data system that allows you to see that. And then I think the other thing that you've heard a bit about is the single pill combination therapy, which is also, given that most of these patients will require more than one medication, starting them on more than one works better and is a convenient way to escalate the doses of both medications simultaneously. We also have found it very valuable for our medical assistants to be skilled at blood pressure assessment and to be available without any financial barriers or appointment barriers for patients to get their blood pressure checked. This is what changed when we decided we would like to adopt a combination of a thiazide diuretic and an ACE inhibitor as a single pill to start patients. So now we've moved that up to about 30% of our patients who start on an ACE inhibitor start on dual therapy. And I'm just going to go right past this because I think I've kind of summarized this. This just happens to be what we call our program for secondary risk prevention, preventing heart attacks and strokes every day phase. But this is what happened to hypertension control in our program over about 10 years. And I think you can see pretty clearly we were not where we wanted to be back in the early part of the last decade. And part of that was we were surprised to learn that that's where we were because we weren't systematically recording and creating in automated databases the ability to see this. So when we took a look, it was more shocking than we might have believed. I can tell you in my own practice, it was stunning. I was certain that I was controlling 80, 90% of my hypertensive patients, and it wasn't the case. And now that number has moved up to about 90%. Now, this morning, Shelley Riard described these things that we're talking about a lot here today as proxy measures. And one of the things that I want to do is and they're kind of intermediate outcome measures when, of course, the real outcomes we're interested in are, do patients have strokes or heart attacks? Do they survive those events? And I think we have all a lot of confidence that doing this, controlling hypertension better, will have that result. But, and doing this, prescribing statins more frequently, will have that result. But the question is, really, does it have that result? And sure. It's just the total number of prescriptions of statins in a decade, just showing that it's a systematic effort to increase statin prescribing resulted in an increase in statin prescribing. The reason I put that in there is partly to point to this, which is part of the discussion of, what is going on now that the guidelines have changed and we're not trying to just push for a target level of cholesterol, but instead are saying prescribe statins for certain people. And how do we think about that? Who is it who we should be putting on these medications? And this is just an effort to say that there's sort of a hierarchy where the question will be, how far down do you come in systematic population-based efforts to put people who need it on statins and not necessarily put people who don't need it? We all have lots of calculators. I have one on my iPhone from the American College of Cardiology, and I put myself in it earlier today. I have normal blood pressure. I'm not diabetic. I don't smoke. My lipids are normal, and I'm on no treatment for any of those conditions. And when I ran this through there, the one risk factor that shows up clearly is that I'm old. And my estimated 10-year cardiac risk for an event is 10%. And the app then says you should be on a mid to high level statin. So, that was kind of a surprise to me, but I think that's part of the question of, where should we be drawing the line? What risk level merits the statin? But there are some very interesting things about statins that go beyond just kind of our conventional understanding that if your cholesterol level was high, you'd like to get it lower. This is a study that was done by some of my colleagues that showed, for example, this is several years ago, that showed that if you're on a statin and you have a coronary event, you have a lesser coronary event than you would have if you were, than you do if you're not on that statin, and similarly true for beta blockers. So instead of having a transmural myocardial infarction, you have something less, maybe just an acute coronary syndrome. And so the result that I wanted to point to is, are we actually reducing the amount of these events when we increase these intermediate outcomes? And the fact is, we are. This is our experience. Again, it ends in 2008 in this study, but it showed that we were reducing the total amount of myocardial infarctions and also apparently particularly reducing the STEMIs, the serious, more serious heart attacks. There's noise in here related to changes in the use of diagnostic tests and definitions and so on, but obviously we were, in the course of this time, reducing those events. And so among the things that may help in reducing the consequences of those events is how well we manage patients when they show up in the hospital with a heart attack or a stroke. And this is a study that showed what happened in our medical centers in Northern California when we implemented the standardized use of an order set in our electronic health record. And when physicians used the order set, as opposed to when they didn't use the order set in the setting of a patient with an acute MI, what was the result? And the result, as you can see here, is that patients got the evidence-based care that we want them to have at a higher frequency when the order set was used than when it was not used. That's nice. And this is even nicer. When you use the order set, the patient was more likely to survive their heart attack. So I think it reinforces the idea, first of all, that the evidence is what we should be following, that those treatments do matter, and that you can do a better job when you have some tools that help you help assure that you do it with greater reliability. And the sort of the combination of impacts here of preventing heart attacks, which is this line, that is, this is the absolute reduction, not on a per population basis, but just what we've seen in our hospitals, gone over this time period from seeing about 8,000 heart attacks a year down to 5,500 or so. That's prevention. And then there's been an even steeper decline in the mortality rate from those heart attacks due to improved care when the patient presents to the hospital or emergency department with a heart attack. These numbers now, remember, this is actually occurring in about 20 hospitals in Northern California. So unlike my recollection when I was a resident in training, I felt like I spent, I don't know, 30% of my time or something like that taking care of heart attacks in the hospital. And now in the course of a year, spread over 20 hospitals, we have 5,000 or so. It's really a not terribly common reason for admission, and it's an extremely uncommon reason to die in the hospital. And I'm sure that this is happening throughout hospitals in California. The other point here is that we tend to think of, this is 20 hospitals, so something in the range of 10 or 12 people a year die of a heart attack in our hospital. And it has caused us to think, because we know that more than 10 or 12 people die in our hospitals each year, what is it that they're dying from? So the future Right Care initiative might want to be about infectious diseases, because patients die of sepsis. 30–40% of all the people in the hospital who die of sepsis.
We can call that back to the future, because we had 2 hospital-acquired infection summits early on, and with your advice, we would reconsider that.
I should be careful what I advise. So another opportunity for acute care of patients with cardiovascular events is about stroke, and this is a specific thing that connects statin use, acute statin use, and stroke. And so among the many things that need to be done, and certainly the timely door-to-needle talk that we just heard is critical, but among the other opportunities to improve the care of patients when they do have a stroke is the use of statins. So here's two papers written by, in this case, Alexander Flint, who's a neurologist at Kaiser in Redwood City, and Steve Sidney, who's here as a co-author on these papers, in fact, on probably most of the papers I'm showing, that looked at what is the impact. This is a retrospective study saying when patients came in with a stroke, what happened if they were on a statin or not on a statin, if they got started on a statin, or if they had their statin stopped. So the first paper showed, I think I skipped one, the first paper showed this in ischemic stroke, which is that patients who were treated with a statin during their acute stroke hospitalization had a greater chance of being alive a year later than those who were not treated with a statin. And maybe even more dramatically, if those patients came to the hospital and had been on a statin and the statin was discontinued during their hospitalization, they had a much more remarkable rate of mortality over the next year. So statins are best. Stopping statins are worst when you present with an acute ischemic stroke. The more, the better. Higher dose statin use had a better impact than lower dose statin use. The sooner, the better. If you got started on a statin early in your hospitalization versus a bit into your hospitalization, you were more likely to be alive a year later, or 3 months later, or at any point. And then the question was, is that just true for ischemic strokes, or might it also be true for hemorrhagic strokes? And there's a lot of controversy over that issue in particular because the statins may increase bleeding. But again, in this case, what was seen was that the use of a statin, and in contrast to no statin, and in particular to withdrawal of a statin, led to increased survival. So again, we have opportunities to prevent these events. We have opportunities to improve the likelihood that someone will survive an event if they have one. And this is another thing that I think is interesting, which is where do the patients go after discharge, which is perhaps an indirect measure of how much recovery they have. And again, if they get a high-dose statin versus no statin or a low-dose statin, they're far more likely to be able to be discharged to home. So I think I've summarized this, but essentially if in-hospital statin use improves survival, likelihood of discharge to home, likelihood of discharge to rehab instead of skilled or custodial care, and that was true. These are, you see two here because it's particularly true if you use the statin, and it's particularly the opposite if you withdraw a statin from someone who's been on it. And this is, again, a retrospective study, but it controlled for a number of potential confounding variables. So that, now looking again in the same way, sort of saying, are we seeing this show up, any of this show up in what we see in our hospitals? We are seeing a reduction again in the total number of patients dying from stroke in our hospitals. That's a combination probably of this reduction in the mortality rate and the underlying reduction in the stroke rate. So fewer patients are having strokes and showing up, and when they show up, they're more likely to get the care that they need and to survive their stroke. One of the points that will be very interesting here is that, like the heart attack, where we embedded the order sets in our electronic health record, Jeff tells me we have embedded about at this time, somewhere in here, order sets that call for statin use in our stroke order sets, and we're going to be interested to see whether we see that number come down correspondingly and whether there's a correlation with the use of the default order set. So I began this by putting this message up saying that our goal 7 years ago was to have an impact on this situation of heart attack and stroke being the leading causes of death and disability in California, and that we've been working on, all of us working on these underlying intermediate measures of our behavior and hoping that it would have this impact. And Steve Sidney, my colleague, has already published data that shows, let me note the date here, 2007, that showed that the work in Kaiser Permanente, at least that has been going on for some time, has in fact already resulted a few years ago, about the time that we began this program, the Right Care Initiative, has resulted in the combination of death from heart disease and stroke declining, so that at this point here in 2008, it no longer is the leading cause of death for Kaiser Permanente members, because it has fallen below the cancer as a cause of death. So I think the point is that I think it's pretty convincing from all of this that we can, through the work we're doing, have an impact on the end results that we want to affect, that is the survival of patients, the reduction of their mortality from heart attack and stroke. And I think we're all on the same path, and just would encourage that we stay on it. And then, in addition to talking about sepsis, the next time we get together, we can begin to talk about cancer. Thank you.
So it's a pleasure to be here again. I missed the last year, at least the last couple of years. This is always an inspiring conference. So Hattie called me up, and talking about statins is already controversial. And that was before the new guidelines came out as to who should take statins or not, which blew the lid off of controversy. So needless to say, Hattie said to me, "Can you come clarify this for us?" And the short answer is no. But undaunted and with 30 minutes to squander, I will give you my thoughts on this and actually, if you'll bear with me, I'm going to run through a number of slides that were already very well covered, and for which I won't have much to add. And I'm not sure.
So while he's looking for that, I'll just say that Tony DeMaria helped us found our first university best practices in San Diego.
Yeah, so I'm going to cover that a little bit too. All right, so I'm going to run through these quickly, so you have to vote in a hurry because I have too many slides. The first question is the number of heart attacks, and this serves two purposes. Number one, whether you know the answer. Number two, whether you were paying attention to the first talk this morning where the answer was given. So you have the numbers there. Everybody vote. And let's show the answer. All right, so a lot of you needed a bit more coffee this morning. All right, the answer is E. It's believe it or not. And so what we know is cardiovascular disease everywhere except Kaiser apparently is still an enormously important problem, and it exceeds all the other causes of heart disease. But again, a lot of this data has already been shown. 1.4 million myocardial infarctions a year, almost 800,000 strokes, surgical revascularizations at 290,000, an annual cost of over $300 billion. Big, big problem, okay? Now, you know, it's been said you have to work hard to get coronary disease. It doesn't come easy, but our society has managed to figure out a way, and there's a lot of things we do that are self-induced disease. This little beauty came from a state fair, and this is it's fried ice cream on top of a bacon cheeseburger. All right, there's 3,000 calories in this little baby. God knows how much saturated fat. Now, this is from the American Heart Association meeting, all right? And we're at the break here, and you can notice there's only one hardy cardiologist that's taking the stairs. Everybody else is on the escalator. So we do a lot of it to ourselves. There's no question about it. Now, you've seen this slide in a little different vantage point, but I'm going to tell you this is the great frustration in terms of preventing cardiovascular disease. And as you've heard, that the number of events is obviously highest in the highest risk group, but the number of people in that group is the smallest. So that if you take a small percentage of a huge group of people, intermediate and low risk, then you'll actually have more events than if you limit yourself to a very small number of people who have a higher rate. And so the frustration to all of us, as you've heard very well, is if we're going to make an impact on the total number of cardiovascular events, we can't just be dealing with this small group of people at the highest risk, because we're going to overwhelm ourselves with the smaller percentage but larger absolute number of people who are at intermediate or low risk. And so what we tend to do is we tend to focus on risk factors to limit things as much as possible in the overall population. And you can see these are the typical coronary risk factors. Not all of them are modifiable. On the right, last I checked, you can't change your age. It's harder to change your gender than it used to be. You don't get to pick your parents, and if you've already had coronary disease, then there's not much you can do. The biggies, though, are over here on the left, the major cardiovascular risk factors, and they're lipids, all right? Primarily LDL, but a low HDL, elevated blood pressure, and tobacco smoking. These other, my goodness, I'm having a hard time here. You're going to get the answer to that one. All right, I give up. But those are the big risk factors we're going to go after. Okay? So the next question here for you. The benefits of statins in lowering cardiovascular events is proportional to, and you see the choices: baseline LDL, LDL reduction, the dose of a statin drug, patient age, and BMI, or none of the above. Okay? So let's go for, let's say, 75 responses. We don't want them to think too hard. All right, 59 will do it. Show us the answer. All right, so it's interesting. The correct answer is B. The correct answer is B. The proportion of LDL reduction that you can achieve tracks very, very well with the reduction in overall cardiovascular events. And that's shown on this slide. And this is a slide. In cardiology, we have big data. We had big data before big data was fashionable. I mean, we don't do any trials with less than 25,000 people in it. And so you look at this, and in fact, you can see 423,000 patients, patient years in this follow-up, and a 39 milligram per deciliter absolute reduction in LDL results in 23% less events, 22% reduction in ischemic strokes. Here's the answer. The benefit is entirely in proportion to LDL reduction. There's no influence on baseline LDL. Think about that. All of you who are sitting out there saying, my LDL is normal. Well, it doesn't matter, because the benefit accrues even to people who have traditionally been in the normal or acceptable range, which we're going to talk about for the rest of it. There's no effect of gender, age, or any other risk factor on benefit. Doesn't matter. Similar risk reduction in primary and secondary. I'm not sure I agree with that, but it's really amazing. Statins do wonders. Now, what about low-risk patients? This is from the Cholesterol Treatment Trialist Collaboration. 22 trials of statins in 134,000 patients. And what you can see, here's risk in ascending level and the percentage of events. And you can see, even in the lowest risk group, that the lower the cholesterol, the lower the number of events. So that even at very low risk, there's a benefit, whether it's vascular events or death, okay? So there's been controversy about statins as long as they've been around, and one of the controversies is, do they work in women? You'll hear this all the time because there's never been a study that enrolled only women. So the data we get is from extracting women in large trials, and this is the biggest meta-analysis, 141,000 patients. And what you can see, as compared to women, men have exactly the same benefit, okay? So in fact, in women and men, based on this meta-analysis, the benefit of statins is about the same. What about the elderly? Now, you know, the definition of elderly is actually getting older all the time. Have you noticed? But if you accept a standard definition here, in this, the mean age was 73 years plus or minus 3. Then in fact, what you can see in this meta-analysis here of almost a dozen studies is that there was a net benefit of statins in terms of reducing overall events. So I think the data is fairly overwhelming, but the best study ever conducted for primary prevention, this is in people who never had a symptom. In fact, this is the Jupiter trial, and what it showed was, in comparison with placebo, people who had no disease whatsoever, and their major risk factor was a CRP, evidence of some inflammation, treated with rosuvastatin, in this particular case, to an LDL of 55, which I hope most of you have as your own LDLs, was dramatically successful in reducing MI, stroke, revascularization, and death. Number needed to treat only 25 to reduce every event. Pretty dramatic. And if you look in Jupiter, whether it was gender or age or smoking or ethnicity or geographic area, hypertension, there was a benefit in every single subgroup. So statins are really, really powerful. But what about side effects? Everybody worries about side effects. And the major side effects are myositis or myalgia, or rhabdomyolysis, or liver function abnormalities. And this is from a huge study called the Prove It trial. And look, these are people with LDL values of less than 40. And you can see there was no increased incidence of adverse effects. And in fact, the incidence of adverse effects in this randomized controlled trial were pretty low, lower than I must admit I see in my own practice. Okay, based upon this, our taxpayer money through the NIH called together in 2002 the National Cholesterol Education Program in 2002 to set up some guidelines for who should have cholesterol treatment. And